Hi, welcome to the Family Resiliency Conference. I'm Ken Moore, and I'm here today to moderate a panel of incredible speakers. What they're going to be here talking about is trauma-informed care. And if you're curious about what that means, stay with us. We took questions from the audience, and their response will be on this show. So please stay tuned for what the communities that came together here today are curious about. And let me tell you about what sectors were here: the Health and Human Services, the clinical sector, and also education were here to learn about how trauma-informed care will help them in their clinics, in their personal interviews with patients, and also in our school systems.
Hi, my name is Bill Stewart. I represent the ACE Learning Collaborative, a group of 7 school districts from around Oregon that have been working on ACEs and trauma-informed practice for nearly 2 years now. And I was pleased to be invited to the Family Resiliency Conference by Trauma Informed Oregon and the MCMINNVILLE CCO, and I think it's a great privilege to be here, and I've already learned a tremendous amount today. As you probably know, ACEs, adverse childhood experiences, are those kinds of experiences that impact a child's development as they're growing and learning and developing their cognitive and social emotional skills. And in our group, the ACE Learning Collaborative, we focused on strategies to try to mitigate those sorts of impacts on kids and learn how to prevent them in the community. And it's been a real eye-opening process for us and our partners that we're going to see as really a change in how we educate kids in Gladstone and other places, and a culture of schools in general. I think one of the long-term benefits of focusing on ACE and trauma practices associated with those sorts of events is that this is probably Oregon's one best opportunity to increase graduation rates, to decrease chronic absenteeism, and to increase college and career readiness among kids that go through our system.
Now we're going to transition and hear from a panel of folks who have implemented trauma-informed care in their own communities. If you guys would like to go ahead and come up to the stage, each one of these folks, which come from physical health, behavioral health, and education, will give us a really unique perspective on what it's like to implement trauma-informed care in the field. So in a moment, they will go ahead and introduce themselves. In the meantime, I'd like to introduce our panel moderator, Ken Moore here. Ken is the host of the local cable talk show, Local Matters. He serves as the Yamhill City Planning Commissioner. He's on the Yamhill County Transit Area Advisory Committee and serves as the McMinnville Area Chamber of Commerce Ambassador. He particularly enjoys serving as a member of McMinnville Sunrise Rotary and is looking forward to the Rotary-sponsored Peace Village Day Camp this summer, held at the Evergreen Air Museum. He's a local contractor with the tagline, "Call me, I can fix it." Please join me in welcoming Ken Moore.
Thank you, Jennifer. Well, we need to get right to it because we could spend a week with these folks. I want to explain the format going forward before I introduce them, because it will make a difference in what you do in the next few minutes. We're going to give each of them 5 minutes to talk about what's up for them, what's important, introduce themselves. But after that, the questions will come from you. So the note cards are on your table, the pens are there, and as I introduce these folks, read their bios and they are speaking, you'll be thinking, well, that's the person I want to ask this question. And be writing that down, hold them up. Jennifer will bring them to me, and then we'll go forward with those questions. So with that, I will introduce each of them and read, not their entire bios in front of you, but in case you haven't had a chance to see it, you need to hear this. Bill Stewart, thank you, is a coordinator of the ACE Learning Collaborative, a group of 7 Oregon school districts that have been exploring ACE trauma issues together for nearly 2 years. In addition to this work, Bill is a member of several Oregon Department of Education and Chief Education Office work groups and advisories, including the advisory for House Bill 4002 pilot, trauma-informed schools. Mr. Stewart has spent most of his career in Gladstone, including time as a high school science teacher, athletic director, vice principal, director of curriculum and assessment, sustainability coordinator, and bond coordinator. And the next sentence is about what he does in his spare time, and I don't believe that, so I'm not going to read it, because he doesn't have any. But you're free to read it in your folder. Dr. Terry Pedersen completed medical school at the University of Alabama in Birmingham and pediatric residency at OHSU. She's a pediatrician at the Children's Clinic in Portland for 26 years. She currently works as a trainer for the Oregon Pediatric Society, START, which stands for START, Screening Tools and Resource Training. She's the pediatric consultant for Oregon Pediatric Access Line About Kids, abbreviation OPAL-K, and serves on the Leadership Committee of Trauma Informed Oregon. Dr. Terry McCall Ellis, LCSW, master's level therapist, behavioral health specialist, and behavior analyst. She is the director of Child and Family Service at NARA, stands for National American Rehabilitation Association Northwest. She provides consultation to treatment centers for adults, children, adolescents, and families related to the development of treatment programs for mental health, behavioral, and co-occurring disorders. Ms. Ellis is a renowned expert on trauma-informed care and is currently working on many projects related to trauma intervention around historical and multi-generational trauma, chronic stress, and post-traumatic disorders. She is doing research and intervention related to the development of trauma-informed mental health and behavioral health treatment systems. So with that, please welcome our distinguished panel. And now I'm going to pass the microphone down the line with the opening question. What has your attention now? And what in this work gets you out of bed in the morning? Where's your passion?
Well, I'll tell you, one of the things that has my passion now is our wonderful two presenters and the information that they provided for us.
Forgive me, Bill, you don't need the microphone, you're mic'd.
That's probably true. And if I use my teacher voice, probably you could hear me without it. So I'm going to describe to you two levels of work that I'm involved in now. One is with the ACE Learning Collaborative, which is a district of originally 7 districts that originally got together almost 2 years ago to look at trauma-informed practices and how they should and could impact our practices with kids and hopefully benefit kids' outcomes in the long run, particularly around some of the mandates that education has had imposed on it over the years. Not that those are bad. And we've expanded our group a little bit. We've included the 2 trauma-informed pilot schools in Oregon, Tigard High School and Central High School, and I think their representatives may be here. If you wave your hands if you are. And there's one over there. Okay, there's right over there, Danielle and Alfonso. And then we've also been working with emerging collaboratives in Columbia County and Clatsop County, who are kind of following the model of study that our collaborative has been working on. What we've been trying to do is get beyond the idea that trauma-informed practice is a one and done. That's a let's go to a workshop and we'll know what to do and then we can move on to something else. We hate the whole concept of the Flavor of the Month Club, which unfortunately seems to be a trend in education that we'd love to reverse. This work, in the opinion of not only my district, but of all the members of the collaborative, really is culture change within schools, practice change within schools at the very deepest level. And that's what we're working to promote, not only among ourselves, but to share with others who might be interested in the work that we've done. So that's the kind of larger level context. The Gladstone level context is that we've really focused in on essentially trying to prevent circumstances from occurring that promote trauma in young kids. In your handouts there, you can see a little pyramid there. We sort of ascribe to the model that's espoused by both RTI and PBIS in terms of zoning activities and responses. And we've been working primarily in the green zone, doing our very best to build resilience, to respond and relate to kids appropriately as they manifest circumstances such as self-regulation, which was mentioned earlier today, and try to build skills and assets in them that reverses those symptoms. But also we try to go deeper and change the circumstances that they have to endure on a daily basis so that those symptoms don't have to manifest themselves. They don't have that need anymore. Just as we were described recently, that Dr. Sims described to us about the lady that had presents in her pocket. And so all of this work to me is so compelling because I see the impact being probably Oregon's biggest chance to improve our chronic absenteeism issues, our graduation, our college-going issues, by having kids more engaged and attuned in school and having teachers and staff and administrators more attuned to the needs of kids and families along the way. Thank you.
Thank you, Bill. And Dr. Pedersen, please tell us what gets you out of bed in the morning. Where's your passion in this work? What are you up to?
My passion in this work is that really that as a pediatrician, pediatricians are really all about prevention. And as a pediatrician, I participated in a number of prevention programs over the course of my career. I participated in smoking prevention and alcohol and drug abuse prevention programs, teen pregnancy prevention programs. But when I heard about the ACE study, I had a potential underlined explanation for why I was having such poor results with all those isolated programs that I was working on. And so it really changed everything for me. How I chose to address that in my individual practice was what we hope to be the ultimate of prevention, and that is the prevention of intergenerational transmission of trauma. And our thought was that if we could identify parents who are most at risk and learn about their trauma histories, agree to support them when they felt most challenged without being judgmental, that we would be able to create a healthier cycle of parenting. So we asked the parents of the 4-month-olds in our practice to let us know what their experience had been growing up. We also asked them to please let us know what their strengths were. We asked them to complete a resilience questionnaire or survey. And we really, again, we want to be real clear, this was not just our looking to see how broken they were, but what their strengths were and how we could build upon those strengths. I currently, as Ken mentioned, I work for the Oregon Pediatric Society. I provide trainings about adverse childhood experiences and trauma-informed care for primary care providers around the state. So that is my work. I'd like to just speak a little bit about what I feel are the challenges in healthcare addressing this, and that is primarily that this is an absolute paradigm shift in the way we think about health, disease, and general functioning. And we're trying to change this on top of a structure that has been in place for a really long time. So that's one of the challenges. Another is that in medicine, we are tremendously protocol driven. We have protocols on how to deal with high blood pressure, how to manage diabetes, how to manage asthma, what to do if someone has a heart attack. And if we don't follow those protocols and a patient does not do well, we're asking to be sued, basically. And so we've really created a whole workforce of physicians who has been told, you need to do it this way and only this way. And so allowing physicians to start thinking in a different way about these things, I think, is one of the bigger challenges. So, but, you know, what a cool thing to get up in the morning for. So, thank you.
Ms. Ellis, same question. What are you working on now? What has your attention? What just you can't get out of your mind?
Okay, I thought you were going to ask me what gets me up in the morning, and I was going to be the only one that was lazy and have a hard time getting up in the morning. They all sound like they're really revved up and ready to go. It takes me a while. But I am truly privileged to do this work, and it's extremely exciting. I'm privileged to be here today to be able to share some time with you. What gets me up in the morning is a variety of things. One, I'll start with the peer context for my life. When I first took the ACEs studies, they stopped doing it about halfway through because I had such a high score. So I grew up in foster care, had many of the experiences our consumers have. And so I wasn't aware that I was a trauma survivor. I just thought I was somebody who was trying to get out of the hole, and went to school as a way of trying to get out of it, and then eventually began to understand that there was a lot more to my early experiences than I thought. And I had the privilege of working my way through the mental health and eventually substance abuse system, and then working a lot in the schools. And so I got to see this. I am Native American. I call my Apache ancestors here today and offer gratitude. But I had the privilege of working in almost all aspects of this system. Started off in providing psychiatric treatment at San Francisco General with very, very troubled people, and then became a psychoanalyst, and then became a child therapist. It sounds like I can't make up my mind what I want to do, but that wasn't really true. I sort of followed the trail of this adventure. And so one of the things I became particularly fascinated by was how inadequate our systems are for addressing this. And I was really renowned as training future therapists to do the work, and as a clinical supervisor, and designing systems for behavioral health. And then what happened was I began to notice that therapists and substance abuse providers and people in the helping professions were the worst at trauma-informed care. That they might know about trauma-informed treatment, but nothing about trauma-informed care. And that everyone was assuming that those are the same things, which they're not. And so I became very interested in the thing that was talked about earlier, that the receptionists, in fact, could be more therapeutic than people with many degrees and lots of knowledge about how to treat people who had had trauma experiences. So I set off sort of redirecting myself into the, looking into that and, what was exactly going on there, and became very interested in the traumatization that's created by the system and the re-traumatization that's created by the system. Also, I am truly a traditional child, so I'm also a child of culture, and I work at Native American Rehabilitation Association and the Director of Child and Family Services, and I also went to lots of trainings on trauma-informed care and trauma treatment, and found that it did not apply to the people that I was working with at all, and in fact, taking a Western approach to trauma-informed care would actually injure the people that I was working with more than they were before. So that's sort of my area of passion and interest today, is speaking those things. I do a lot of training. I try to spend more time less time with professionals and more time with consumers of our services. I truly appreciate the opportunity to be of service. I'm also on Trauma-Informed Oregon with Carrie, where I have the privilege to work with other people and being able to look at some of the policies and practices that we have here in Oregon. So I thank you for your time and attention today, and I'm hoping for some good questions.
Well, not having received any questions yet, I have a few of my own. Terry, now we have two women named Terry here, Terry with an I and Terry with a Y. Terry with the Y, Terry with an I spoke about a paradigm shift, and you and I spoke about that on the phone earlier. Would you speak more about this paradigm shift that's taking place in healthcare?
Me?
Yes.
Okay,
Okay, well, great. We'll go.
Well, again, as late as the 1900, the main things that killed people in this country were infectious diseases. People died of pneumonia and influenza. They died of tuberculosis. Those were the top three. And then gastroenteritis was the fourth one, diarrhea and dehydration. And then there was childbirth. And so that's what killed people. We live a lot longer these days, and as we've lived longer, and then we discovered antibiotics that changed some things. But if what we know about health and disease has so much to do with what we experience emotionally as children, the attachments we have to our caregivers, and then what we experience in the first months and years of life, and that can set a trajectory for our health. That is the paradigm shift. It's not about infectious diseases. It's not just about poor choices in terms of healthcare. It's a poor choice to smoke. It's a poor choice to shoot up heroin. It's a very different way about thinking about things.
Thank you. Well, we have our first question. And I'll just let people raise their hand that could best speak to it. The question here is about Western approach, injurious examples. We've heard that today about a Western approach that maybe needs to be re-examined.
Yeah, I'm happy to speak to that. This is where Terry is also working in the area of multi-generational and historical trauma and the transmission of trauma from one generation to another, which I think was evidenced by the presentations this morning. When people say things like, well, the events are over, times have changed, move on. There were distinctive changes that were created in brains that are still being transmitted, and further trauma exacerbates. I can't speak this morning, but you know the word I'm trying to use. But one of the things that happens is, for example, a community that believes that a community that's more communally based and works more as a group, without intending to, providers who are well-intentioned with a more Western-based approach can actually contribute to the erosion of further culture and trauma. And that's kind of hard to describe in just a few seconds, but what I'd say is that our people are now dependent on services that are so far away from our cultural beliefs and values that they actually violate and taking those services, the tenets of our culture. Does that make sense? And so it actually makes the problem worse because the biggest, I would say the biggest protective factor related to trauma, but also the greatest intervention related to trauma is community and family. And so we're very concerned about the erosion of families and communities. And many of the things that people recommend in very well-intentioned ways, like the focus on individualism, etc., instead of a family communal culture, can actually contribute to further traumatization and further distance from the very things that will help you. And we're very grateful for the help and assistance, and may be needed, like we talked about, like actual interventions, like medication sometimes, but unless that's done in the context of the value of the bigger picture for the people, then our well-intentioned efforts can actually cause further damage. I don't know if I'm making any sense. I need head nods because I'm not very articulate. These people really impress me, and so I worry a lot about whether I'm just wasting your time. But maybe not your head.
You're not wasting our time.
I disagree with Terry. I think she's actually quite articulate, and it's an honor to work with her. I'll just add on top of that, I think that because there were such changes and let me try to get this up even farther. Yeah, oh, that's much better. Okay, I think. So I think that because our focus on treatment with medicine was really effective in terms of infectious disease, and our treatment treatments were really effective when it came to surgery. You know, he would cut and cure, he would heal with steel. And so we really went down that pathway, and it really is important. If you have a physical trauma where you're in, say, for example, in an auto accident, then having a trauma surgeon is a really good person to have around. But if we really look at the social determinants of health, as Terry was saying, community, connection, the social determinants of health determine lifelong susceptibility to disease. It accounts for about 90% of our health, as opposed to what I, as the healthcare provider, could actually provide for people. So it's lacking.
If I could add one more thing to that, which goes with what Terry's saying, is that the coaches I'm talking about are entirely relational. So trauma-informed care makes a great deal of sense from that perspective, because it's supposed to be about relationships and how to have relationships with people. So sometimes people want me to train on trauma-informed care, and I say, why don't we just train on relationships? Okay, and that's not to violate trauma-informed care, but I think even that puts it in a context that's a little bit removed from the issue, which is how do you have relationships with people professionally and every other way. You know, we like to talk a lot about boundaries and stuff, but I worked for a while at University of California, San Francisco, and I worked in the medical school, and I'm not a doctor, but what they would have me train on is bedside manner, which I think was the hardest topic for all the medical students. They kind of hated it because it wasn't about what Terry's talking about. It was about how you talk to people and how do you behave, and, you know, how do you relate. So I just want to put that context that I'm probably not too good at trauma-informed care, and I'm not very good at all at relationships, but that's the focus of trying to learn it.
In talking about relationships, I certainly agree with both Terry's. Let me give you a little anecdote as to why I think relationships are a really key piece in the K-12 environment, and certainly in the pre-K environment too. This is about a task that I was given when I was vice principal of our high school. A wonderful job that truly needs to be trauma-informed, and I'll admit that I was less so than I am now. My superintendent gave me the task of analyzing kids that were unsuccessful in our system, trying to figure out why. And so I took about 7 years of unsuccessful kids, and you can frame those however you want, you're probably right. And one of the things that we found, among others, is that in a majority of cases, after interviewing the family, talking to the kids, doing all sorts of various reviews of records and so on, we were able to pinpoint pretty clearly, in a majority of cases, what the thing was that got them off track. And almost universally, it was some aspect of trauma impact that began to manifest itself. And the thing that saved kids, because we also looked at kids that were sort of in that same place but managed to get back on track, was the establishment of strong relationships that they didn't have previously in their life somewhere, with a teacher, a coach, a pastor, a club mentor, some other caring, supportive adult that gave them the social, emotional support that they didn't have, and the ability to self-regulate that they hadn't learned. And by doing those things, those kids ended up being successful even though they were kind of on the same trajectory as some of their peers. So we've taken that to heart in our practice, and we really feel like the social, emotional aspect and the relational piece that kids come to us with is a real true predictor of A, their current trajectory towards success, and B, a real indicator of things that we need to do to support them, not necessarily punish them. And that's where the culture shift in not only my district, but a lot of the districts in the collaborative has been taking place.
We just have a few minutes left. ashamed to say. I hope this has been an introduction to these people and a resource to you. They will be available during lunch. We do have a few more minutes. I'd like to ask, Bill, starting with you, and you two if you want to add, before we go to our final advice question. Schools are constantly implementing new programs. And how have you been able to engage schools and other sites, getting staff on board? What's your secret?
Well,
I think the secret really is, what we did in our collaborative for this purpose was we started with the very basic data from the ACE study and from the WSU academic ACE study that you're probably familiar with by Chris Blodgett. And we spent a lot of time digging into that to show superintendents and counselors and principals and vice principals and teachers what happens and the dose-response relationship between trauma impacts on kids and their outcomes. And if you haven't seen the work from WSU from Chris Blodgett, it's very similar in concept to what we saw in the original ACE study. We had Vince Folletti come and talk to our group at length for an entire day. We had real personal conversations with him. And that sort of thing turned a room which was about 50-50 supportive of the whole idea, and maybe that was generous, into about 99.9 to nothing, being supportive of the idea that trauma-informed practices were essential for us to move forward. And the people that were the most skeptical were people like vice principals, I admit to being one at one time, who really thought that punishment was the answer to poor behavior and other things. And let's do more of the same thing. As a science teacher, there's a guy that I think you maybe have heard of. His name's Einstein. And there's the thing that he apparently did say, that continuing to do the same thing over and over and expecting different results is the best definition of insanity that exists. And so that's where we kind of looked ourselves in the mirror and said, let's not be insane. We need to change our culture.
Anything to add on that?
Well, the only thing I would add is that approach that I've taken recently is to have a trauma-informed approach to taking care of staff. And I think once they've had that experience, then they're willing to also share that with other people. So sometimes I think we need to make sure that we start at both ends of the spectrum when we intervene, and that probably was part of the approach to the cell people. But when people are resistant, I usually try to give them a taste of a trauma-informed approach, even to their resistance to the ideas, and that's the best seller that I've found in terms of moving that along.
We have a wonderful stack of questions here. What it did was it had you focus on who you want to talk to right after this is over with, and please come up to them with these questions. I'd just like to give you an opportunity to wrap up. What can we do first might be a question that you want to address. What's something that surprised you? What concerns you? Maybe we'll just go down and have you put up, if you have anything you want to add to what you said today.
I think in healthcare, probably one of the most important things is whatever you're doing, start small. We also have, because we're so protocol driven, we have to have all the answers. We have to have everything figured out. Start small, and then you're going to know what your next steps are. That wherever you progress to, it's going to say, oh, but now we do this and now we do that. As long as we keep our minds open to that, because this is going to be a very long process. It's a process.
I agree. This is a generational change that we're making, and it will take time. And I would encourage in all sectors to make sure that you feel like you and your staff, your colleagues have a really deep understanding of what we've heard about today already, what we'll hear about more later. Because there are folks out there that are they're putting out what we call snake oil. And it's rebranded stuff that's really just putting lipstick on a pig. And it really isn't effective. It isn't trauma-informed, but it sounds good, and it'll cost you money, and it'll set you back. And I speak from experience on that one. We have learned our lesson about not doing our homework ahead of time, and not really knowing where we're going, and not thinking far enough down the road. Terry's right. Incremental steps probably is the best you can hope for, but with the goal in mind.
Well, that's our time for today. I hope, will you please join me in expressing your appreciation and to the YCCO for bringing this incredible panel. We're going to be doing this conference every 2 years, so stay tuned. It was a crowd of over 300 people here today, coming just from our community here in Yamhill County. So it's the place to be, and hope to see you in 2 years.